So classically, we use steroids as a first-line treatment for acute graft versus host disease. And about 50% of the time, that's all what you need. You will get a response, and then you work through tapering down your steroids, as I said earlier, as fast as you can, but then you'll be faced with flare-ups of acute GVHD. And the 50% of patients who either do not respond to steroids or, as we defined earlier, they become steroid refractory or dependent, we use ruxolitinib. And the way we do this is, originally we use both, and as we see responses, personally, and most transplanters will share this view with me, we start to taper down the steroids. So, first steroids, if there's no response, you add the ruxolitinib, they overlap, and then you start to taper down the steroids and stay with the ruxolitinib. Unless there are side effects to ruxolitinib, intolerance, other problems, then we start to taper the ruxolitinib first. There are a multitude of adverse events for, now we have three variables. You have acute graft versus host disease, you have high-dose corticosteroids, and you have ruxolitinib. As most patients will have some sort of adverse events, either from the disease or the steroids or the rocks. The most common event are infections. These patients are intensely immunosuppressed from the GVHD, from the steroids, and from the ruxolitinib. And a small percentage of patients on REACH2 had to discontinue ruxolitinib, and the most common cause was infections. So how do we manage the adverse events? We just manage them as they come. Steroid adverse events, diabetes, we treat the diabetes, deconditioning, physical. I personally push for physical therapy and occupational therapy. Hypertension, we manage that hypertension. As far as ruxolitinib, the most common initial reaction is myelosuppression. So in the first couple of weeks, you might see a decrease in hemoglobin platelets and see. The good news is this does not stay for a long time. So most people will have a little dip, and then they go back up and they plateau. So if that decrease is severe for whatever reason, I personally support these patients with growth factors or transfusion, but invariably in most of these patients, unless they have other causes, their blood counts will go back up and then they plateau. The problem is, as I said, there are many factors. So graft versus host disease itself as a disease, it decreases, it is a myelosuppressive condition. And with intense immune suppression, people might reactivate their CMV, other infections, particularly fungal infections, and in a significant number of patients, relapse of the primary disease might occur. So this is as complex as medicine can get.